So I welcome all on this master class, and today's topic will be on the oculoplasty, and this will be, I think, very good presentation and beneficial for all the residents as well as the general practitioner also. So Dr. Malay verma needs no introduction, but she is the senior consultant and oculoplasty expert in the Ranchi. And after doing his MS from the PGIMS Rohtak, he did the fellowship in oculoplasty in orbit from the Shankar Nitralaya, and he also served for some time as an associate consultant there. He is the recipient of the multiple academic honors. He has been awarded many awards for the Best Paper Award, B.S. Gupta Best Paper Award, Dr. Manjul Pad Video Awards, and is also the past editor of the Jharkhand Journal of Ophthalmology. He also published many papers, including 25 articles. So I welcome Dr. Malay Burma for this webinar for his talks on the oculoplasty. He will share his clinical parts related to the oculoplasty. So Dr. Malay Burma, please, the floor is yours. So please start your presentation.
Yeah, very good evening. Am I audible?
Yes, you are audible.
Okay. So, thank you for the opportunity. And today I'm going to speak on eyelid tumors, how to make a diagnosis. So, before we embark on this, um, the first question that we need to ask is why do we need this presentation or why do we need to talk on this topic? Because lid carcinoma are pretty commonly seen in our OPDs, and it is not very difficult to make a diagnosis. But then, once you are faced with two patients of this kind, what do you think? Which one is a chalazion? Which one is a malignancy? So here you face a dilemma, and then you need to dive deep into the this topic. So one of them is a chalazion. This one is a chalazion, and this one is a sebaceous gland carcinoma. So once we take history, will patient will always give a history of either a non-healing ulcer or maybe there is a spontaneous bleeding from any lid lesion, or there might be a recurrent swelling in the same site of the same eyelid. There might be chronic congestion, and there might be sudden increase of a pre-existing swelling. Now there are six basic signs of malignancy. The first one is ulceration, but even though there is ulceration, there will not be any pain on in the lesion. Second is induration. Once we palpate, there will be a firm feeling. Third, the margins will always be irregular, unlike in a case of a benign lesion where the lesion is usually symmetrical. In case of a malignancy, the lesion is not symmetrical. It will have very irregular edges. Then telangiectasia, which is a dilated vessels, there will be seen either supplying the mass or around the mass. Fifth is the pearly border seen in basal cell carcinoma. And the sixth is loss of lid margin architecture, means either there is a loss of eyelashes or the loss of lid contour. So now um, once we have the knowledge of all these six basic signs of malignancy, we can use them to diagnose various conditions. So let me give few examples. Let's say this lesion. If we see this lesion, there is a ulceration here. There is induration once you feel this. The lesion is irregular. Telangiectasia is not visible. Pearly borders is not there, but there is loss of architecture, loss of lashes in this region. So many signs are there, then that means this is most likely a malignancy. Another, here if you see the margin is regular, there is no telangiectasia, no loss of lashes. It's a symmetrical lesion, so it's most likely a benign lesion. And then if we see this one, there is though there's some loss of lashes here, but otherwise other signs are absent. This is a seborrheic keratosis, which is a benign lesion. Then once again, another lesion, another example, you see loss of lashes in this region, and then it has got irregular edges, and though telangiectasia and pearly borders are absent, but other features are there. So this is most likely a malignant lesion. Another case, same thing, except for telangiectasia, all other features are present. So this is a malignant lesion. Then once again, another case here, though telangiectasia is visible, but other signs are absent. So this is a benign lesion. It is a cystic lesion. So what are the common lesions affecting the eyelid? There are some lesions which arise from the skin. The malignant ones are basal cell carcinoma arising from this layer, squamous cell carcinomas arising from this layer, and malignant melanoma. Whereas the benign lesions, there are a lot of them, acrocordon, which are also called squamous papilloma, seborrheic keratosis, as I had shown before, cutaneous horn, various kind of cysts, and molluscum contagiosum. Now, there are other lesions also which don't arise from skin per se, but they are arising from the adnexal structures. So, malignant lesions arising from this meibomian gland, which are a modified sebaceous gland. It is called meibomian gland carcinoma, and even sebaceous gland carcinoma can be there elsewhere. And then benign lesions that arise from this and small glands, they are different. So Zeiss glands, you will get a sty when there is acute infection, and marginal chalazion will be there. With from arising from meibomian gland, you'll get internal nodulum, or in a chronic cases, you'll get a chalazion. So these are some benign lesions. You see, this is not very difficult to diagnose, a capillary hemangioma. And here, if we see this cyst, there will be white debris on the dependent portion of the cyst. This is the apocrine hydrocystoma. These debris are cellular debris because apocrine glands, their mode of secretion is by the destruction of the cell vesicles. So that's how the secretion comes. So this deposit will be seen. This is called apocrine hydrocystoma. And if you see this lesion, it is called squamous papilloma. And other benign lesions, if you see, this is external nodulum, and this kind of a horn-like structure, this is called cutaneous horn. And this is once again rarely seen condition where you get symmetrical pigmented lesion on both the lids. So these are called kissing nevus. Another benign lesion, keratoconthoma, where some amount of hyperkeratinization is there in the center. And this is a orbital, this is a lid varix. And then if you see, this is another case where there is a nevus. And then if we go further, these are some malignant lesions. This is the sebaceous gland carcinoma. And then this is not very difficult to diagnose, basal cell carcinoma, squamous cell carcinoma arising from the conjunctival part. And this is a malignant melanoma. And then there are some masquerades also, which look like a malignant lesion. If you see here, once again, going by our six features, you see there are, except for telangiectasia and pearly borders, all others are there. But this was not a malignant lesion. This was a case of aspergillosis. Another, here you don't see any loss of lashes, no other signs are there. But if you do a lid eversion, you will notice this kind of feature. So this is a suggestive of a meibomian gland carcinoma. Then once again, if you see, these are three similar looking conditions. These are molluscum, molluscum, molluscum. This is a nevus. And then this is not a chronic conjunctivitis. This is a sebaceous gland carcinoma with a pagetoid spread. Then once again, if you see whether this, you are sometimes faced with a dilemma whether this is a viral lesion, whether this is a nevus, and whether this is a hemangioma. But then this is milia, and this is the pyogenic granuloma, which is arising from the conjunctival side. Once again, another form of pyogenic granuloma. Actually, pyogenic granuloma is a hemangioma. So that brings me to the end of this topic, and yeah, I'm open for questions if anybody has any questions. Any questions from any PGs?